My objective today is to discuss the optimal choice of therapy in first relapse of multiple myeloma. Why is the therapy of first relapse so important in multiple myeloma? Well, for three reasons, actually. The first is that the duration of response decreases when increasing treatment lines from the first relapse, second, third, etc. So the duration of second response is a major driver of overall survival. The second reason is that relapse treatment is more and more difficult at each step of the disease. First, because the clones is becoming more and more resistant to therapeutics. And second, because over time, the treatment toxicity increases and the bone marrow function decreases. The third reason is that the proportion of patients treated at relapse decreases at each line of therapy, and it is based on a large series of almost 5,000 patients treated in different countries in Europe. And this slide shows at the first relapse, approximately 60% of patients are treated in the real life. At the second, only 38%, and it decreases at each relapse. So what was the optimal treatment of relapse in multiple myeloma in the past? It was very simple. It was a combination of bortezomib plus dexamethasone or lenalidomide plus dexamethasone, and this was based on the randomized studies which are on this slide. But we now know that bortezomib and lenalidomide are always used frontline. That means that the incidence of early resistance to bortezomib and or to lenalidomide is increasing rapidly. So we certainly need second generation new agent. This slide shows all the new agents, including the last ones, but I want to focus on this group with first a new immunomodulator, which is called Pomalidomide, two new proteasome inhibitors, Carfilzomib and Ixazomib, and two antibodies, Elotuzumab, which is an anti-SLAMF7, and the Daratumumab, which is very important, an anti-CD38 antibody. We know that Pomalidomide in combination with dexamethasone can be active in patients who are resistant to bortezomib and lenalidomide. But maybe the most important study testing one of these new agents was the Endeavor trial, which compared carfilzomib at the dose of 56 milligrams square meter plus dexamethasone versus bortezomib plus dexamethasone. And this slide shows the well-known results with a benefit in favor of carfilzomib compared to bortezomib, both for progression-free survival and overall survival. And this was true also for first relapse treatment. But very rapidly, very important studies comparing the standard double combination bortezomib plus dexamethasone or lenalidomide plus dexamethasone were designed, and they compared the triple combination with the standard regimen plus one of the second generation new agent, Pomalidomide plus Bortezomib Dex, the OPTIMISMM study, Carfilzomib plus lenalidomide Dex, the ASPIRE study, Ixazomib plus lenalidomide Dex, Tourmaline study, Daratumumab plus lenalidomide is Pollux, plus Bortezomib is Castor, Elotuzumab plus lenalidomide is Eloquent 2 study, and I will not discuss this one because Panobinasta is not used for first relapse. Here are the results that you all know of the 4 studies performed with a comparison of lenalidomide dexamethasone and lenalidomide dexamethasone plus second generation new agent. Here, Carfilzomib, here, Elotuzumab, Ixazomib, and Daratumumab. And you see that all these studies show the benefit in terms of progression-free survival of the triplet compared to the doublet. Same is true with Bortezomib, the Candor study with Daratumumab, and the OPTIMISMM study with Pomalidomide comparing with Bortezomib dexamethasone. So the summary of all these trials comparing a triple combination to a double standard combination is on this slide with the lenalidomide dexamethasone containing regimen, and you see that all 4 studies were significantly showing benefit for the triple combination, but the most striking result was with Daratumumab with a hazard ratio of 0.37. And the same was true with Bortezomib-based regimen. And again, the Candor trial, the combination with Daratumumab yielded the best result with the hazard ratio of 0.39. So the summary is that triple combinations are always superior to standard double combination, Velcade Dex or Revlimid Dex, in terms of response, progression-free survival, and in some study, the follow-up is long enough to show differences in overall survival as well. And it's seen, this benefit is seen in all situations, whatever the age, whatever the ISS, whatever the number of prior lines, the previous stem cell transplantation, and whatever the cytogenetic risk. But also one conclusion is that Daratumumab combination appears to be the best and appear to be really a breakthrough, especially when looking at minimal residual disease achievement. And you see on this slide that the triple combination with Daratumumab obtained much more MRD negativity than the doublet at the level of 10 to the minus 5 and even at the level of 10 to the minus 6. And as you know, MRD negativity is associated with a prolongation of progression-free survival, and sustained MRD negativity is also associated with a prolonged overall survival. Speaking of Daratumumab, there is another anti-CD38 antibody which is currently developed. It is Isatuximab, and this slide shows the 3 major randomized trials. One in frontline treatment and 2 in relapsed refractory multiple myeloma, and I will discuss one of them later. So how can we choose the best of all these regimens? Well, it's not easy because there are multiple factors which drive treatment choice in first relapse. First, factors which are related to the patient, the age, the comorbidities, for instance, renal impairment, performance status, and the tolerance to prior therapy. So the existence of risk associated to the patient himself can change the objective of first relapse treatment. And we do think that in frail and old patients, the objective should be to achieve response, but without taking risk of toxicity. We know that some of the second-generation new agents are well tolerated in elderly patients and can be used as well. For instance, Ixazomib, Elotuzumab, or Daratumumab. And this slide shows the results of the Daratumumab randomized trials, Pollux and Candor. And you see that patients over the age of 75 do better with a triple combination than with a double, both with lenalidomide in the Pollux trial and with Bortezomib in the Candor trials. But the challenge is not only age. And actually, we have not so many information regarding the treatment of relapse in elderly patients because many old patients are not included into clinical trials. But we know there are other problems: increased morbidities, tolerability of available therapeutics, and you have here the list of complications associated with each of these new agents. And we have also the higher risk of infection, of thrombosis, of neuropathy. So patients are not only older, but they are also more frail. And for those patients, I do think that in many instances, attenuated regimen may be preferable. For instance, lower dose of lenalidomide, 15 milligram instead of 25 milligram per day, and the so-called RVD light with Revlimid, Velcade, and low-dose dexamethasone, but with reduced doses. Coming now to the treatment of first relapse in younger and fit patients, and here, obviously, the objective is to achieve the best possible progression-free survival, and here, the quality of response matters. So it depends on other prognostic factors. These are related to the disease, and of course, the aggressiveness of the relapse, the short interval between the first remission and the first relapse, and the prognostic factors such as ISS and cytogenetics are very important to consider. When looking at the randomized trial comparing triple combination versus double, we already know that in all conditions, triple combination are superior. This is the example of high-risk cytogenetics, and you see here that with carfilzomib, with ixazomib, or with daratumumab, the triple combination is superior to the double in patients with high-risk cytogenetics. The problem is, until now, we have no face-to-face of this triple combination. So how can we make the choice? But my personal opinion is that we have to make the choice on this very important factor, which is refractoriness to previous treatment with lenalidomide or bortezomib. And also this one is very important, is treatment availability, because of course all these drugs are very expensive and they are not affordable in all countries. So let's go to sensitivity to lenalidomide or bortezomib. And first, lenalidomide. These trials have been performed in lenalidomide sensitive or lenalidomide naive patients. And when looking at the result in first relapse, you see that the triple combination with carfilzomib is good. The triple with ixazomib is less good, except maybe in older patients without prior transplantation. But again, the best appear to be daratumumab, Revlimid, dexamethasone, with a median not reached at 3 years. The same is true for bortezomib-based combination in lenalidomide-exposed or lenalidomide refractory patients. These are the results of the Candor trial and of the OPTIMISMM. You see that is approximately 26 months, and here with pomalidomide, 21 months. However, the main problem is lenalidomide refractory, because in the previous trial, there were patients who were exposed, but not all were refractory. And when looking at truly refractory patients, which is very frequent because lenalidomide, as I said, is almost always used frontline, then you see that the results are less good. In the Endeavor study, almost 30% were truly lenalidomide refractory, and the median progression-free survival was 8 months. The same with daratumumab, and the same with pomalidomide in a large number of lenalidomide refractory patients. So we do have a challenge with lenalidomide refractory patients because the result in these trials were not optimal. But we have new possibilities, which are based on the second generation new agent. And you have here a list of possible combination, pomalidomide-based, daratumumab-based, elotuzumab-based, or isatuximab-based. And I would like to focus on 3 randomized trials, which actually added 2 new agents. The ELOQUENT-3 trial, which was in third line, patient had to receive 2 prior lines of treatment. But you see that in patients who were refractory to lenalidomide, vast majority of the patients included into the trial, the triplet elotuzumab pom dex was superior to the doublet pomalidomide dexamethasone. The same is true with isatuximab in the recently published ICARIA randomized trial comparing is Rituximab Pomalidomide Dex versus Pomalidomide Dex. And again, it was a trial in third or fourth line, not first relapse, second relapse, or third relapse. But again, in patients who were refractory to lenalidomide, which was a vast majority of patients recruited in this trial, the triplet was superior to the doublet. But maybe the most attractive combination will be Daratumumab Carfilzomib at the dose of 56 milligram plus low dose dexamethasone. The Candor randomized trial was recently published as a late-breaking abstract at the ASH meeting in December, and you'll see on this slide that the triple combination is superior to the Carfilzomib 56 plus dexamethasone combination in terms of progression-free survival, which was not evaluable with 17 months median follow-up time versus a median progression-free survival of 16 months. But what is important, considering the topic of this presentation, is the results in lenalidomide refractory patient. And you see here that the median progression-free survival is not reached with a triple combination and is significantly better than with a double combination. So to conclude, here are my proposals for first relapse in fit and younger patients, and they are based on refractoriness to lenalidomide, and we can divide two groups of patients who are not refractory to lenalidomide, and then we can use lenalidomide for treatment of first relapse. And in my opinion, the best combination was studied in the Pollux trials, the Daratumumab Revlimid Dex, which is superior to Revlimid Dex. There are, of course, other possibilities with proteasome inhibitor, Carfilzomib, Ixazomib, and also with Rituximab, but in my opinion, the best is Daratumumab Revdex. In countries where Daratumumab is too expensive, and even Carfilzomib or Ixazomib are too expensive, the best treatment is simply Velcade Revlimid Dex. For patients who are refractory to lenalidomide, and again, it's becoming a very important problem, I do think that the best combination will be the Candor, one tested in the Candor trial, Daratumumab Carfilzomib dexamethasone, which was superior to Carfilzomib dexamethasone at the dose of 56 milligrams. There are other possibilities which are acceptable. Daratumumab Velcade dexamethasone, Daratumumab Pomalidomide dexamethasone, Rituximab Pomalidomide dexamethasone. In countries where Daratumumab is not available, of course, you can again try, if it's possible, Carfilzomib-based or Pomalidomide-based combination. But if you have no money enough, simple VCD and VMP are the only possibility, but of course they are much less active. I would like to finish by the problem of autologous transplantation. One of important factor to consider is whether the patient has received or not previous stem cell transplantation. If the patient has not received autologous transplantation as part of his frontline treatment, there is a consensus that autologous transplantation should be considered standard at the time of first relapse. But for patients who receive autologous transplant frontline treatment, the question is much more difficult. And the German performed a randomized trial comparing after Revlimid dexamethasone induction, autologous transplantation versus Revlimid dexamethasone maintenance. And you see that at least in terms of progression-free survival, the difference is not striking. So knowing that we have no combination which are much better than Revlimid dexamethasone, my personal opinion is that autologous transplantation shouldn't be the primary treatment for first relapse in patients who have already received autologous transplantation for frontline treatment. So my conclusion are the following. Of course, the treatment of first relapse is changing since bortezomib and lenalidomide are almost always used upfront. We now know that triple combination with any second generation new agent are more active than Rev dexamethasone or Velcade dexamethasone. I try to demonstrate that the anti-CD38 based combination with daratumumab and more recently isatuximab appear to be the most active, but the question for the future will be how will we treat patients who receive daratumumab upfront, which is more and more frequent since the result of the Halcyon trial with daratumumab, melphalan, prednisone, and Maya trial with daratumumab, Revlimid, dexamethasone in elderly patients, but also results which are coming in the field of transplantation with the Cassiope trial and the Griffin trial. So it's really a challenge for the future. What will be the treatment of patients relapsing after daratumumab frontline? And finally, as I said, the price of all these new agents are a concern in many countries and are not affordable, and is raised to difficult choices in those countries. I would like to thank you for your attention.
Hello, my name is Saad Usmani. I'm the Chief of Plasma Cell Disorders Division and Director of Clinical Research in Hematologic Malignancies at the Levine Cancer Institute in Charlotte, North Carolina. And I'm going to be talking about managing myeloma beyond the first relapse. These are my disclosures: research funding, consulting fees, as well as speaking fees. I'm going to start off the talk by just sharing what has already been discussed in earlier talks, just setting up the stage of our current treatment paradigm for newly diagnosed myeloma patients. We treat patients initially with a combination of 3 or 4 therapies as induction therapy. For transplant eligible patients, they go on to receive autologous stem cell transplant preceded by high-dose melphalan, and then patients are placed on maintenance treatment. Supportive care is also important, so attention to bone health, pain management, psychosocial support, considerations around infection prevention are also important considerations. But we do appreciate that majority of our newly diagnosed myeloma patients do have a disease relapse eventually and need to be managed accordingly. And with that in mind, I'm going to share with you the current landscape and how patients actually get to their first relapse, just so that we're setting up the stage. There are patients who are going to receive 3 or 4 drug regimens with or without a break, or 2 drug regimens in certain instances with or without a break before they relapse. Then there are patients who are going to get 3 or 4 drug regimens as part of their induction treatment, then get their stem cell transplants followed by maintenance as they're getting into relapse. So, there's a whole gamut of factors that go into decision making about how to approach patients in their first relapse. That part has been covered by my colleague in another talk, but we can kind of divide patients into 4 criteria or 4 subgroups when we're talking about that first relapse. And this is kind of our approach. So patients may be len naive or sensitive, and bortezomib naive or sensitive. And in those situations, we prefer to use a len-based regimen. You see those 4 options. For us, we tend to use more DRD. Then for len refractory, yet bortezomib naive patients, we would have both a POM-based or a PI-based regimen. So, in our practice, DVD or DPOM-D would be those choices. Then if patients are bortezomib refractory and len naive, then again, DRD would be a reasonable choice. KRD, ERD, ELO-RD are going to be other choices. And then len and bortezomib refractory patients is where more POM and carfilzomib-based regimens are coming into play in our practice. And then, we of course pay attention to patients who may benefit from either a second or a salvage autologous stem cell transplant, and we pay attention to that. I want to talk a little bit about Daratumumab Dex because we have a phase 1b experience that was published by Ajay Chari demonstrating 60% overall response rate for those patients with a PFS of 8.8 in patients who were PIMID refractory, 4 median prior lines of treatment, and 30% Carfilzomib refractory. And there are 2 other case series that have looked at patients who are Dara or POM or both refractory, where the response rates have been roughly around 55 to 60% in Dara or POM refractory patients, with a median PFS of at least 4 months. And in patients in one cohort from the Emory experience, for patients who have not had any exposure to Dara or Pomalidomide in the past, their median PFS can be quite long, kind of mimicking what we saw in the Pollux clinical trial as well. So it's a good regimen to consider. Phase 3 data is still not available for Daratumumab Dex, but we have a comfort level with this particular regimen for our Len and Bortezomib refractory patients based on this. But I want to talk about the other anti-CD38 monoclonal antibody, isatuximab, which is a chimeric anti-CD38 monoclonal antibody. The ICARIA trial looked at relapsed refractory myeloma patients who had 2 or more prior lines of treatment, including lenalidomide and proteasome inhibitor, with no prior therapy with pomalidomide. And the randomization was combining isatuximab with PomDex and comparing that to PomDex, with the primary endpoint being PFS, secondary endpoints being overall response rate and overall survival. So the ICARIA trial showed that the combination of ISA-PomDex had about 60% overall response rate compared to 35% on the PomDex, with VGPR or better rates of 32% versus 8.5%. And the median PFS, which was the primary endpoint, was reached. So the study was positive, showing 11.5 months PFS in the ISA-PomDex arm compared to 6.5 months in the PomDex arm, with a hazard ratio of 0.59. The overall survival, the median had not been reached in either treatment group. There appears to be a trend favoring the 3-drug combination, but we have to wait for the further follow-up to actually see these data pan out. The other important group or trial combination regimen in this setting is the combination of pomalidomide, bortezomib, dexamethasone. So this was the OPTIMISMM trial that looked at patients who had 1 to 3 prior lines of treatment. But again, talking about the pomalidomide-based regimens for those lenalidomide refractory patients, I think this is lenalidomide refractory yet bortezomib sensitive or naive patients. This is an important clinical trial with that perspective for that patient population. So POM-Vel-Dex was compared to Vel-Dex in a large randomized phase 3 study here. The primary endpoint was PFS, and the treatment was continued until progressive disease or unacceptable toxicities. And if you see here, the overall response rate with POM-Vel-Dex was superior to the 2-drug regimen, 82% versus 50%. VGPR or better rates were 52.7 versus 18.3%. If you look at the PFS and the intent to treat patient population, it was 11.2 months versus 7.1 months. And if you start looking at patients who were Len refractory, you see the same benefit, 9.5 months versus 5.6 months. So again, this is an important regimen for pomalidomide eligible patients who are still sensitive or naive to bortezomib dexamethasone. Looking at the subgroup analysis across the board in terms of age, performance status, high-risk cytogenetics, we saw benefit in favor of pomalidomide bortezomib dexamethasone combination. Then another important study in this setting is actually a randomized phase 2 trial looking at the combination of elotuzumab Pom-Dex, comparing it to Pom-Dex, and the primary endpoint was progression-free survival. So this was a fairly large randomized phase 2 study, and the primary patient characteristics, as you can see in the slide, were fairly well balanced. What's important to note in this slide is that 90% of the patients were refractory to lenalidomide in the elotuzumab arm, 84% refractory to lenalidomide in the control arm. So this is a very relevant patient population to that len refractory subgroup. And if you look at refractory status to both lenalidomide and proteasome inhibitor, it was roughly 70% across the board for the study. So looking at overall response rate in the elotuzumab group, as you can see, was 53% versus 26% in the control group. You can see VGPR or better rate of 20% in the Elo-Pom-Dex group versus 8.8% in the control group. In terms of PFS, median PFS, I thought was quite impressive, 10.3 months versus 4.7 months in the control group, and the median OS of the control arm was about 17.4 months, and that for the experimental arm had not been reached when these data were updated at EHA last year. This brings us to another important trial. We're talking about carfilzomib combinations. So daratumumab was combined with carfilzomib and dexamethasone in the Candor trial, which was a large randomized phase 3 study with a 2-to-1 randomization schema. So, for every one patient who went on carfilzomib dexamethasone, 2 were randomized to daratumumab carfilzomib dexamethasone. A total of 466 patients underwent randomization. This study also had landmark analysis for MRD negative CR rates at 12 months as well as 24 months. The primary endpoint was PFS, which was met after a median follow-up of about a little over 16 months. The median PFS in the KD arm had been reached at 15.8 months, whereas that with the KD Dana arm had not been reached, with a hazard ratio of 0.63 and a p-value of 0.001. Looking at the subgroup analysis, they were all favoring the 3-drug combination compared to the 2-drug combination. What's important to note here is prior lenalidomide exposure and refractoriness. Patients also fared better with the 3-drug combination compared to the 2-drug combination, and this is clinically very relevant. The overall response rate was superior in the 3-drug combination compared to the 2-drug combination, and the depth of response with MRD negativity was almost 10-fold higher at the 12-month mark. MRD negative CR rates at 12 months at 10 to the minus 5 were 12.5% in the 3-drug arm compared to 1.3% in the 2-drug arm. Treatment emergent adverse events were numerically higher in the 3-drug arm compared to the 2-drug arm, most important being infections. Of note, treatment-related fatal AEs were seen, 5 in total on the 3-drug arm and none in the KD arm, and 4 of those 5 events were infection-related, as denoted on this particular slide. So the overall conclusion from the Candor trial was the 3-drug combination is significantly superior in terms of PFS, depth of response. The treatment effect on PFS was generally consistent across the clinical relevant subgroups, with specifically, in the lenalidomide exposed and refractory patient population. There appeared to be an imbalance in the treatment emergent fatal AEs, which was partially explained by longer treatment exposure, age, and frailty status, and 4 of those 5 events were infection related. And in the same way, and I want to also talk about the Bellini trial because this becomes relevant for a very important patient population. So last year, we heard concerning news about this particular trial, which was evaluating the combination of venetoclax, bortezomib dexamethasone, with bortezomib dexamethasone being placed on hold with concerns about a higher incidence of deaths on the experimental arm, even though benefit was being seen in terms of PFS. So these were the data that were being seen at that time of the median PFS in the venetoclax arm was 22.4 months, and in the placebo was 11.5 months. But if you look at the number of events of death, there were 41 events that were seen in the venetoclax bortezomib dexamethasone arm compared to 11 events in the bortezomib dexamethasone arm. So the FDA had halted the trials and wanted us, the investigators, to take a deeper look into why this was happening. And what was observed was that majority of the benefit, the PFS benefit, was being derived from patients who had either the translocation 11-14 or high BCL2 levels by quantitative PCR. And these data were shared at ASH 2019 by my colleague Simon Harrison from Australia. And this shed a very important light on the subject. I think many of us felt that venetoclax is likely going to be our first biomarker-driven therapy, and that's probably where this is headed. So, is venetoclax active in myeloma? Yes. Probably the subsets that benefit are the translocation 11-14 and BCL2. The deaths that occurred, were cardiac or infectious in nature, so there might be a role for prophylactic antibiotics and IVIG. In certain patients, but venetoclax is moving forward in clinical trials, and we have more questions than answers right now, but we have to stay tuned. I do believe that this will move forward and become an option for our patients. So for our second relapse and beyond, our pathways again, when we think about patients, we think about patients treatment schemas based on prior exposure or refractoriness to the proteasome inhibitors, the immunomodulatory drugs, and then also with daratumumab. So you can see these these four subgroups of patients where we would think about having a DPD or DKD kind of regimen for DARA naive or sensitive patients if they're len or bortezomib refractory. If they're DARA refractory, then KPD becomes an important regimen. Pomalidomide Dex also becomes an important regimen in our schema. We do use DARA KD as well as carfilzomib with cyclophosphamide dexamethasone quite a bit. And for translocation 11-14 in the United States, we do have access to venetoclax along with dexamethasone, and sometimes we are able to add a proteasome inhibitor, based on some of the preliminary data as insurance allows us. I do want to talk about a few other important options. So exportin-1 pathway inhibition has been demonstrated with a exportin-1 inhibitor group of drugs, with selinexor being the first-in-class drug. It helps block this XPO1, which prevents the tumor suppressor proteins escaping the nucleus membrane, amongst other specific proteins. And then selinexor is being looked at in combination with both carfilzomib as well as pomalidomide in the broader umbrella trial called the STOMP. And some data were shared at ASH, which will become very relevant to us. We know that selinexor dexamethasone is an approved option when given twice weekly along with dexamethasone. We also appreciate that it has gastrointestinal side effects. Interestingly, when it's combined with carfilzomib in this phase 1 study, we're not seeing as much GI side effects and as were reported at ASH, and that's probably because of the lower weekly dosing of the selinexor along with the weekly dose of carfilzomib. The same is true for as you can see with the DLTs here, with the 80 milligram Q week and the 56 milligram per meter squared of carfilzomib Q week. No DLTs have been observed as when this was reported, and enrollment is ongoing. Same is true for the pomalidomide-based combination. These data were presented by Christine Chen from Princess Margaret Hospital in Canada, and the dose that appears to be best combined with pomalidomide and dexamethasone is selinexor at 60 milligrams given once a week. So I think both of these options are coming up for our PI imid refractory myeloma patients along with selinexor, and they will become clinically quite relevant. The other important, some of the other important ASH abstracts included the TAC-079, which is an IgG1 lambda monoclonal antibody that binds to CD38. It is a low volume subcutaneous shot that can be given. So this study was presented by my colleague Amrita Krishnan with 34 patients who had 3 median prior lines of treatment. In the overall intent to treat cohort, the overall response rate is 45%. So kind of, sounds something similar to daratumumab, but it appears that it's low volume and it can be given subcutaneously, without co-formulation, and appears to be fairly active. So, stay tuned. This would be an interesting option, important option for our patients. Then we heard about the BCMA bispecific monoclonal antibody CC-93269 in relapse refractory myeloma patients. These data included patients who had 5 median prior lines of treatment, in 30 patients that have been treated in the dose escalation portion of the study so far. The overall response being seen as about 43%, which is very encouraging, and we have to keep an eye on this particular drug. We also heard about the CARTITUDE-1 Phase 1b 2 study with J&J 4528. So this was a CAR-T trial looking at a group of 29 patients with median of 5 prior lines of treatment, showing 100% overall response rate, a CR rate of 69%, and patients, 27 of the patients continued to be in remission at the median follow-up of 6 months. So data looked very encouraging. The safety profile in terms of CRS and neurotoxicity looked very promising with this particular drug. And then we also heard about the BB21217 CAR molecule, which is essentially the same CAR molecule as the BB2121, but it's co-cultured with PI3 kinase inhibitor BB007 to enrich for T cells displaying a memory-like phenotype. These were very early data. We only got good follow-up for the first cohort with 150 million CAR T cells given, and not enough follow-up for the higher cohort. So I'm looking forward to seeing more data with this construct. The early data in terms of the degree of neurotoxicity and CRS appear to be consistent with what we've seen with BB2121 as well. And then, we also have to look at new novel molecules to come. So the CELMoD CC122, CC220, and CC480 are coming down the pike with combination with other drugs. MCL1 inhibitors are also in the clinic. Bromodomain inhibitors are also in the clinic. There are MDM2 inhibitors being evaluated for myeloma as well. And it's been a while that we have heard about more proteasome inhibitors coming down in the clinical pipeline, but we know that Harousseau and Bortezomib have been percolating for a little while in clinical development. Hopefully, we'll get to hear more about these data as well. So, just to summarize, myeloma is not one disease. You have to consider, how the disease is manifesting itself. You have to pay attention to disease biology, prior therapies before you pick that next line of treatment. You have to think about patient characteristics as well, of course. Some of the new small molecules appear to be cleaner than the old ones. Majority are oral agents, so this will become a more convenient option for our patients. It still remains to be seen how we combine the IOs based therapy. They appear to be disease biology agnostic, and we still need more follow-up and data. In the high-risk patients, we need to see how we can combine them with the existing and the new small molecules. And then there are new CARs on the horizon. Protection times still remain an issue. Bispecifics will likely give CARs a stiff challenge, especially if we start seeing a response rate north of 70% or so. Having said that, I will conclude my talk here. I thank you for your attention, and I'll be happy to take any questions from all of you.